Can someone type and confirm? Can you guys hear me? Because we will start shortly in a couple of minutes. Okay. All right. Thank you, doctors. We will start in just 3 to 4 minutes from now. We'll just wait for a couple of more people, and I'm gonna begin. And I hope see my screen as well. And yep. And this session exclusively we made for people who actually failed in MRCP. Okay, yeah, it can be MRCP 1, 2. Okay, it can be MRCP 1 or 2 or basis. Okay, first thing I would like to tell, there is nothing wrong in failing an examination. It's perfectly okay. And just because someone passing all the paths without any issues doesn't mean that person is going to get through a specialty training in UK or become a best doctor or better doctor. I will tell you some examples before I begin. Okay, and this is particularly people who are here and who are just upset or like heartbroken because you guys failed in either of the paths. Okay, I'll tell you. There are two people I noticed. Like, okay, I'll tell you a couple of examples. First is a candidate A. Okay, let us name a person named whatever you call her maybe like Neha. Okay, this person I know, she started her IMT along with me. She cleared her part 1 and part 2 successfully in the first year of internal medicine training itself. And she cleared PACES as well. Okay. And her PACES mark that time, the PACES total is 172. She scored 171 out of 172. That's absolutely a big mark. That's a huge margin. Went all the way to UK and couldn't sustain there anymore. Came back all the way to India only to be working as a SR in a private hospital. Example number 2. Okay, you call this guy Nitin maybe. All right, these are real life examples. I'm just concealing their names, okay, because I don't want to broadcast anybody's name. Okay, this person I know failed in part 1 2 times. And he failed in part 2 3 times. Just imagine the plight. 2 times you are failing in part 1 and 3 times you are failing in part 2. Since this gentleman is also an IMT UK offshore trainee, he got fast track PACES slot and failed in PACES again. Again, PACES, fail. Just imagine anyone in this situation would have just immediately quit and gone back to something else, especially in Indian scenario. If you think of, they would have gone back to some NEET PG. If you're in Pakistan or Bangladesh, maybe you would have gone back some FCPS, or some people overall quit this pathway itself and go back to USMLE or Australian Medical Council exam or MCQQE exams in Canada. So this person never gave up. Again, he applied through MTI pathway and he ended up as a trainee in UK. And within 2 years of struggle, that is, I think during 2020 and 2021, he cleared all the parts of MRCP, and 2 years he had work experience in cardiology. Now he is a specialty registrar in cardiology in Cardiff. Okay, there are so many examples I can keep on listing out. Okay, this exam, anyone failing for any choice doesn't mean you are dumb or you don't know things or you are incompetent. Not at all. Okay, just you are not working out certain things in the right way. That's what I would say. Failing in PACES, I would say it's not just lack of hard work. Sometimes it's luck also, right? Because different examiners, their mood and whatever going to happen in their homes or in their personal life before the day of exam, it all affects things. Okay, so failure is not something that is going to pull you down. Okay, we are going to start now. The very first thing we are going to start is top 10 reasons why people fail in, this is L, people fail in part 1 and part 2. We made an audit. Okay, when I was back there and when I was back here also during my IMT, we made an audit. In the audit, we just wanted to know, we gathered a couple of people who failed and we asked them like what went wrong with them. This is not just audit I made today. This is something we have been doing like for quite a while. We had a valid set of data and we compiled I compiled personally top 10 reasons why people fail in part 1 and part 2, especially. Paces is an entirely different thing. I'm not going to talk about paces right now. This is entirely different thing. This needs a lot of things. This needs your hard work, then your exposure to patience. This needs a good mentor for you and a partner for you. Ultimately, you need God's grace, or otherwise other people call us luck. Without that, you cannot pass. Some people are really hardworking. They are so slick in examination, so good, but the examiner is going to be absolute moron, or like absolutely they are going to come like in an idiotic mood. They are going to spoil your life there. But 1 and 2 is not like that, because you are entirely going to be evaluated by the system. All right. Also, each and everyone is going, one of you going to get the same questions. There is nothing like somebody in one center is going to get a different question, the other center is going to get something different. No, it's not going to happen like that. Okay, it's not going to happen like that. So this needs a different approach, and clinical examination, that needs a different approach. So for part 1 and part 2, what are the top 10 reasons? We are going to see one by one, and after that I'm ready to answer your questions. Then we are going to work out 2023, some of the very recent question bank, like 10 MCQs we are going to work out in the med expert style, in my way, like how we work on MCQs. Okay, so that's how we are going to start and end this session. So quickly, without wasting time, I'm going to tell the very first reason and how to avoid the pitfalls. And some of you may be here going to very first time you guys are going to attempt your part 1 examination. This will be absolutely helpful for you, because you're going to potentially avoid all the pitfalls which we are going to mention right here. Okay, the very first reason most people fail in all the 3 parts, including paces, is premature attempts. What is a premature attempt? Premature attempt is someone comes and without any preparation or giving themselves enough time frame, they just go all the way and jump into the exam only to crack. So first common thing I noticed in people who failed, according to our data, is premature attempt. They won't give them enough time without knowing where they are exactly standing. They'll just think, okay, this guy I know, he just studied just 1 month some notes and he cleared the exam. I will also do the same thing. Then you will be in absolute deep trouble. You will be absolutely in trouble. So never ever make any premature attempts, because this is your money and this is your time. This is not some little money, I believe, right? Nearly in Indian money, it's somewhere close to 65,000 now. It's the payment of any duty medical officer. I think it's more than that. You cannot make any premature attempts. You should have a solid time frame. You should first know where you stand. And we have a lot of strategies. We told you, even in our preparatory sessions, we have told you to assess where you are standing right now. So based on that, take your time and attempt without any preparation, without any proper preparation, without having a valid timeline where you are, what you have to do. If you are going to attempt, that's what you call as a premature attempt. That will certainly push you down all the way to failure. This many candidates I have seen, especially I have seen such thing in people who have some basic internal medicine degree or some degrees like MD, DNB candidates or FCPS candidates, attempting like this and getting into trouble. Especially them in those postgraduate candidates, I have noticed. They wanted to attempt the exam in an extremely short time frame, like for example, like 2 months, 3 months. Yes, there are people who could have cleared, but it doesn't mean you will clear also in the same time, unless you assess yourself properly where you stand. So avoid any kind of premature attempts. That will certainly going to end up in your downfall. Next thing is engaging in book mafia. This is one of the common thing even I'm seeing in group. People are asking, I just don't know why, books like CMDT, okay, CMTD. Some people are telling in the groups, like, I want to download and read current medical treatment and diagnosis for MRCP. Is it so? It won't help you anyways. Trust me, years of experience in teaching MRCP 1 and 2, and now starting with the paces as well. None of these books are going to help you in passing MRCP examination. I'm talking about all the 3 parts of MRCP examination, including part 1, part 2, phases. Harrison's is my favorite book. I read in and out from my undergraduate days. Oxford Handbook of Clinical Medicine, yes, take it when you're going to go into the hospital as an SHO or medical registrar, when you want to refer something. Absolutely, that book is a golden book. Davidson's, I never opened that much. And Current Medical Treatment and Diagnosis, I don't use because I'm a avid user of UpToDate and BMJ best practice. None of this book is going to help you to pass your part 1 and part 2. I know it may sound absolutely offensive to some of you. Never engage in book mafia by buying and downloading and reading multitude of books. You will only end up wasting your time, absolutely wasting your time. Please don't do that. Please don't do that. These books may look fancy. It may sound great if you tell, oh my God, I'm reading Harrison's, I'm reading Oxford, I'm reading Davidson's, I'm reading Kumar and Clark, I'm reading Goldman and Cecil, what not book you want to read. You can even go ahead and read individual specialty books also. Trust me, that is not going to help even 1% in passing your MRCP 1 and 2 examination, because MRCP 1 and 2 examination needs smart work. It does not need this much bigger books. You don't need to read them at all, and don't waste your money and time over this. If you want to learn medicine, you want to explore more depths in medicine, you want to go into academic medicine, you want to learn more clinicals, absolutely you can use it. Even though nowadays it's all more of a what can I tell it? It's all came in a very compact mode. You don't go and refer big books. We use UpToDate and we use British National Formulary. We use Talkspace for any toxicology cases. Things have changed. Definitely nothing wrong in reading. These are good books, but never ever do this. Many people spoiled their MRCP part 1 and part 2 results, and many people messed up in paces as well by talking complicated things, by reading unnecessary textbooks, and only to confuse the examiner and getting failed in the particular station. Please don't do that. Second common mistake is engaging in book mafia and reading unnecessary stuffs and unwanted textbook that is going to put you down severely. This I have taken in our audit. We have found a lot of people tried doing this because somebody in the WhatsApp group says so. Please don't do that. Please don't download these PDFs and don't confuse yourself. You don't need all these things. Trust me, you don't need all these things, and you can never ever complete the entire medicine. Medicine is a big ocean. You can never complete the entire medicine before you're going to appear for MRCP 1 and 2. Neither RCP is expecting anything from you like that. All right. Number 3, what we found out is wrong guidance. Okay, wrong guidance. Many people can guide you in a wrong way. Oh my God, I read this notes and I passed. What you will do, you will go and buy the notes and you will think you will pass, only to fail. This is wrong guidance. I'll tell you why it is a wrong guidance. Okay. Not everything will work for every single person. What works for me may not work for you. What works for you may not work for another person. That person could have been having an extensive knowledge in internal medicine, and he would have studied some random notes made by a random person online, and he would have definitely cracked the examination. But that's not true for everyone, right? There may be a person who want to start from the scratch. If he is going to start with the notes as a scratch or the baseline, he is going to fumble. He is going to absolutely fumble. There are a lot of wrong people sitting and guiding people in an absolutely wrong way. That's not how it is. Okay, first you should know who is guiding you, where he is taking you, and the wrong guidance can absolutely result in wrong results. Absolutely. So be careful who is guiding you, what he is taking you up to, what is going to happen. So MRCP, third important thing people fail are due to the wrong guidance. Fourth, what we noted is a messy preparation. A messy preparation is some people, they'll go ahead, they'll study today for 4 or 5 hours. Okay, maybe today is like Sunday. Sunday he will study for 6 hours. Then Monday he will go for duty, he will study for 1 hour. And Tuesday maybe he will be having a duty of no studies. Then Wednesday, he may be going out with family party, no studies. Then Thursday, he gets scared. Oh my God, I didn't study for the last 3-4 days. I'm going to study for the next 2 to 3 hours. Then Friday, party time, no studies. This I have asked a couple of students who got into trouble because of a very messy preparation without a proper schedule. This will again put you down. This will again put you down in the result. I'll tell you only one thing. Consistency is must. Even if you are going to give only 3 hours a day, please give it consistently at one point of time on that particular point of the day. If you are going to mess up like this, studying few hours in one particular day, then not studying for 2 days, then again turning up and studying for 3-4 hours, that is absolutely going to push you into trouble. I don't want any of you who is listening to this lecture to get into that trouble. Please have a proper schedule. Monday, this time to this time, you're going to study. You have to go and sit and study. There is no way, no room for any kind of distraction, no room for any negativity, no room for any other emotions. Just you have to go focus your mind and study. Please, if you are not going to be consistent, that is going to be put you into trouble. You know how people succeed? People succeed not because they are intelligent. Some people, hard work is must, but a consistent hard work matters. Hard work on Monday and Tuesday, then 3-4 days of laziness, and then again hard work is not going to do anything. Consistently do it. Many people fail in MRCP, especially in part 2 and paces like examination, because they lack consistency. One day they will go, 4-5 days they will think they will go and attend some short paces course, paying lakhs of rupees, and they will attend for 4 days. They will see all the patients there. Then 1 month they won't do anything at all. Then they will suddenly go and appear before the examiner. Then by the time they auscultate, they'll be like, oh my God, this is ejection systolic murmur. No, this is a pan-systolic murmur. Oh my God, there is a diastolic murmur heard there. Is this a collapsing pulse? Is this atrial fibrillation? Like, why? Because lack of consistency. So all the parts of MRCP needs consistency. Never ever prepare without a schedule. Messy preparation, again, put down a lot of people into trouble. Fifth thing I noticed, okay, a lot of people still think reading notes is going to give them a pass. It's not. See, I have read these notes, okay, read these notes. What it says? Some of the notes are really funny. It says like fever, sore throat, IgA nephropathy. I mean, man, what is that? How it is going to help? How it is going to help you by any means? How it is going to help you by any means? If somebody is having a fever or a sore throat, and that is IgA nephropathy, if you read something like that, what is going to give you? Nothing. You will memorize something and go, where they will make a question from RCP with a lot of pitfalls which you won't understand. The answer would be something else. So reading this type of notes and thinking you will pass the examination by reading these notes or using these notes as your baseline preparatory material, again going to put you into trouble. I've seen a lot of candidates coming back and telling, I asked them, how you prepared for your examination? I said, I read these notes. Then after that, I worked out MCQs in one quiz bank, and straight away he appeared for exam. The result is fail. I don't want any one of you to get into trouble because like this. Because reading notes or overindulgence in any notes is not going to help you. I am not telling or talking ill about notes, because among the notes maker, the top notes maker, which many of you are reading, he is my best friend. Okay, he is my best friend from Egypt. We are very close. With all respect to that buddy, I am telling you, nothing wrong in reading notes, but never ever overindulge in notes, and never ever use notes as your baseline preparatory material, especially students who have already lost the examination. Do not do that. Do not do that misadventure. Keep it. When you have to read, once you finish the baseline reading things, which you have to read after working out the MCQs, after working out the past papers, just a day or two before exam, maybe a week before exam, when you're laying down in bed or when you're traveling, you just want to go through, that time notes will help. There is no doubt in that. But opening notes and reading and then randomly or attempting MCQs is not going to help you at all. Trust me. 6, another important and a very, very important factor that put many people down is lack of revision. It doesn't matter how you read. If you don't revise again, you are going to be in trouble. That's reason number 6. Okay, if you are not going to revise 100%, it is going to land you up in trouble. There is no doubt in that. There is no doubt in that. Okay, so revision is must. I would suggest at least 3 rounds of revision. 3 rounds of revision. Make a schedule in a way at least you 3 times go through, especially at least 3 times you go through before your exams. You have to make a schedule like that, so that to be on a safer side. If you don't revise, it's like you have read actually nothing. Trust me, if you don't revise, it will just go off from your head. Just go from your head. Same thing goes for PACES candidates. You are appearing for PACES, keep on practicing, keep on touching the patients each and every day. Do something, learn. Otherwise, all of a sudden, you will fumble there. Keep revising. It should come spontaneously within you in a like a reflex. Okay. If you just hit your tendon, the reflex happens spontaneously. You don't go and tell, please move your hands like this. Nothing. You just stretch the tendon, hit, the reflex comes. Like that, answers and concepts should come at a reflex level for all of us. When it's gonna come like that, you won't have to worry about anything. Trust me. Revision is a very, very important thing. If possible, have a good study partner. Have a good study partner and revise. Trust me, if you revise and do these things properly for both part 1 and part 2 together, shouldn't take you more than 10 months to clear and come out. It doesn't matter what level you are. Next, another important thing which puts a lot of people into trouble is memorizing without knowing the concepts. If you are going to study MRCP 1 and 2 and you don't know the concepts, you are going to be in trouble. I don't know how many of you are aware of that thing or not. Now MRCP 1 and 2 board has been changed. Examination board has been completely changed. Like how they brought a new changes in PACES, PACES 23. They brought a lot of changes. Okay, there is 2 communication stations now, and instead of 10-minute station 5, that is brief clinical consultation, now they have clinical consultation for 20 minutes each. There is change in the PACES. Likewise, they are going to bring out some change in the concepts and everything for part 1 and part 2. Though the examination and marks are going to be the same, however, now you can expect different level of questions, because they are also very well aware, a lot of people mugging up and doing this, doing that, and coming and clearing the examination, and ultimately they are not performing at par with UK trainees, because whatever they do, they are going to compare your scores with the UK trainee scores. Okay, I can show you proof, I can show you evidence how RCP works. Okay, how RCP thinks. The board has been changed. So if you think you can memorize everything without knowing the concepts and you're going to go to the examination, if they slightly twist something, then that will put you into trouble. Always remember that. So learn the concepts. Just simple thing. If you don't know anything, stop. Even if you don't have a tutor nearby you, you can just YouTube or find something. There are many short video clips are there explaining things very beautifully. Just learn, then go ahead to the next question. Never ever attempt to memorize a lot of things and go ahead for the examination. That will certainly put you in trouble. Then another important reason I found personally why people fail, especially the MRCP PACES, MRCP 1 and 2 examination, is people who ignore the past papers. Of course, you're going to be in trouble. This is the best thing I would suggest, at least last 5-year paper. Okay, 5-year, if you take even 3 diets per year, 5 3s are 15. This 15 past papers, you should work out at any cost. You should work out in exam settings. Okay, you should work out in exam settings. You should work out in exam settings. All right, exam settings is what? You just set 3 hours alarm. 3 hours you set an alarm, start the past papers, working out. Within 3 hours you have to finish in exam settings. Be honest with yourself. Don't open any side tabs and search for the answers. Be honest, straightforward, start working on the questions in exam settings. Okay, that's the first thing I would suggest. In exam settings, you should work this. All right. Then Other thing is failure to learn from mistakes. I'll explain you why and how, what I mean by this exactly. For example, you are working out an MCQ. Okay, you are going wrong there. Many people, what they do, okay, I'm wrong, blah, 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 this is okay. Next, I'll go ahead. No, that's not how it is. That's not how it is. If you go wrong in a particular MCQ, stop there. Then note it down in your notebook. Note it down in a notebook where you went wrong. Immediately read about it. Immediately read about it. I'll tell you some questions asked here. Which book to be read for MRCP? I'll come there. What are we expected to revise? I'll tell you all those things. Okay, I'll come to that. Note it down immediately. Read about it. Okay, read about it. Then once you finish reading about it, then again revise. Then revise. You have to make it like a cycle. You have to do it repeatedly, especially the concepts and questions which you are going wrong. Keep revising and discuss that with your study partner. If you have trouble, ask a mentor, ask your senior, ask whoever is nearby you. I don't understand this concept. Please explain me. Do it. You have to do it. Because if you are going to just skip out the questions, you are going to go wrong and keep on going to the next question without understanding things. That is going to put you in trouble. 10 people who fail because they don't know the exam. What does mean by that? Somebody don't know the exam. What is that? Somebody doesn't know the exam means. I'll tell you. Many people think MRCP questions, MRCP 1 and 2 questions has only one right answer. Absolutely wrong. MRCP 1 and 2 MCQ questions can have more than one right answers. Always remember, more than one right answer. MRCP can have more than one right answer. But what they expect from you is the most appropriate answer. Most appropriate answer. All right. What is meant by most appropriate answer? Okay, I will explain. All right. A DKA patient is coming. A patient is with DKA. He is coming to your hospital. Okay. And you can find him having a fever or a tummy ache, and you can find acidotic, ketotic breathing, respiration goes ups and down. You can find everything. DKA is diagnosed. You can find ketone in his urine. You start everything. Okay. Should you hydrate him? Yes. And after giving insulin, should you give him potassium supplement if potassium goes low? Yes. Should you treat the infection? If there is an infection is the underlying cause, maybe an UTI? Yes, you have to. But what is the immediate thing you will do if they ask? Always going to be the hydration. After assessing ABCD and settling down the patient. That's what they expect. All these things you may be doing for the patient. There is no doubt in that. You will be doing. But what they expect is at this particular point of situation, at this particular level, for this particular patient, what you are going to do for the best interest of the patient. That's what they expect. The answer, other answers may be right. Okay. A, B, C, D, E. If you see the option, A may be the wrong answer, B could be the right answer, D could be the right answer. So how do you choose between this B and D? Is choose the appropriate one. What is needed for the patient out of the best interest of the patient. That's what MRCP expects. That's why many people get confused. Oh, sir, this is also right. That is also right. Why this is right? See which is the most appropriate thing you have to do. That is what RCP expects from you. Nothing else. That's what they are expecting from you. Right in the shoes of a medical registrar, what you are going to do for that particular patient at this particular point of time. That's what they are expecting. They're not expecting anything else. They're not expecting anything else. So if you don't know the exam, then we are going to be in trouble. Especially this happens in all part 1, part 2, and as well as paces setting. Okay. Some of the questions I will answer before going to the next slides. Okay. Very first question is what we are expected to revise. Revise first thing, concepts. Then the questions which you went wrong. And if I always suggest notes, your own notes. Please don't buy notes of other people. Others' notes was not going to help you. Okay, only your notes, own notes is going to help you. Other people can write, read whatever that is. That is not going to help you. Have your own notes, revise it, revise the concepts when questions goes wrong. Another question: what books to study for MRCP? See, basically, I will tell you, I don't recommend any books to study for MRCP. If you work out the MCQs, read the proper explanation, and attend. I'm not telling just you have to attend only MedExpert or any decent course that teaches you decent things. Take notes. It's more than enough. However, there are someone of you who may be like, I want a book because maybe there is nothing wrong in telling your basic medical knowledge or basic concepts with general internal medicine is little lagging. You may need a book. In that case, if you are on that level, I would suggest only 2 books. One is Kumar and Clark Clinical Medicine. Then down the line, I may put Oxford, but this book should be enough. Only if you feel your clinical knowledge is not up to date. So I'm sorry, that line you need to start little from the scratch. Otherwise, the best thing to read is the guidelines, because entire MRCP 1 and 2 questions are based on guidelines. That is your NICE guidelines and your SIGN guidelines, then European guidelines. These 3 guidelines plays a vital role for MRCP. They are not going to take questions from the book. They are going to take their MCQs, their answers based only on these guidelines, because after writing any MCQs, they have to provide a guidelines. So they are going to it's going to be entirely based on NICE, SIGN, and European Society guidelines. Nothing else. Absolutely nothing else. So if you desperately want a book, Kumar and Clark Clinical Medicine, as per me, I will never ever recommend you, and please don't buy big books which you can't even weigh in your hands and read unwanted theory. If you want some basics in general internal medicine, Kumar and Clark is decent enough for MRCP. Listen, once again, I'm talking only about MRCP. I'm not talking about internal medicine as general. If you want to know internal medicine in depth, then you have to go and read specialty books. For neurology, you have to buy Adam and Victor. Then for gastro, you have to buy Yamada. And for nephrology, you have to buy Brenner and Rector. We have been through all these books. Okay, for teaching purpose, I used to go through all these books because I love academic medicine as much as I love clinical medicine. So if you want desperately a book, this is the best book you can go for. Rest, guidelines. Guidelines, you don't need to read the entire guidelines, just to read the approach and just take notes, few lines of notes. That's enough. How many concepts are there? RCP tests, hardly 60-65 concepts, not more than that. Even for PACES, the same thing. I challenged last time PACES people, whoever went for PACES, I made a PDF for them and I showed them. These are the list of topics you are going to see. And exactly beyond the topic, not a single word, a single case came in the PACES. We compiled in such a way. I challenge them, if you find anything out of this for your PACES examination, you can come back and slap me. Not a single person got any case out of our list. So this is the books you need to read. And the next question is, where do we access the past papers? Okay, past papers is in past test. Besides that, nobody has a proper source of past test. And you can find recalls in some Facebook groups and all, but that won't help. Past test actually compiles everything in an MCQ format. And we, in our med exam expert, we also have our past papers. You can use any of the source, whichever you like. We also have the past papers. And another question has been asked, sir, I gave my attempt in October. When we were practicing, we had a lot of information, but in real exam, hardly it had 2-liner question. Most of them were 1-liners. With this understood, we need to know each and every word of the hard topics being asked repeatedly in past papers. Understood. Yes, that is true, doctor, because now there is something that is arising called ambiguity. Because when we gave part 1, that is long back. Okay, that is long back, 5-6 years back, when we gave our part 2, part 1 and all, that time it was entirely different. What happened during those days is we used to have a very long stem of MCQ. MCQ itself will be like half the page. By the time you finish reading, you will have your own giddiness. That much of big thing. We used to take and sharpen our pencils, underline multiple times and confuse our brain, then finally take an answer. Nowadays, I have seen the questions are just 1-2 lines, 1-2-3 lines. That's it. It is ambiguous. I do agree. But that report has been made to RCP because some people felt some questions are just too ambiguous to choose a right answer. But again, the best way to counter it is being strong in your concepts and getting to read between the lines. Even if it is 2 lines, there will be something that will point out to the clue. Okay, there will be something. We are going to work out 2023 exam questions now shortly. Okay, so that is the best defense for you against this ambiguity. Which MCQ banks are good for preparation? I don't vote for any particular bank, but anyone who is working out, who is preparing for MRCP examination, 2 things I would like to tell 2 question banks. Never step in, especially people who have failed, without fully completing your past test and past medicine question bank. And above all, with this, your past papers. This is the bare minimum I would suggest. Both are important. Both are important. Okay, both are important. And next, how can I feel confident about my preparation? Okay, both the questions are same. I think the question below is another doctor asks us, when can we feel we are ready or not for appearing beforehand? Okay, both are the same. When you are going to feel absolutely you are confident. I'll tell you one thing. I said last 5-year past papers, okay, and last 5 year matlab 15 past papers at least. In the 15, if you can score close to 80% in at least 80% and above in at least 9 to 10 papers, I think you are good to go. Okay, you are good to go. If not, just think little retrospect. The only way you can be feeling confident is working out MCQs multiple times, reading the concepts multiple times, discussing with multiple times, so you get everything within you in a reflex level. Okay, that's what we call it as a reflex level. Reflex level it should be. Easily it will be seen a candidate who prepared like that, a candidate who didn't prepare like that. In paces, it will be easily seen. Candidates who practiced with the patients in clinics, they'll come just few seconds, they'll finish the case and they'll tell you what is the diagnosis and walk away. People who didn't do that, they'll come, scratch the head, go there, stand here. You know, some people come even without knowing which tuning fork to use. I've been a surrogate for paces examination for quite a long time. Once a patient took a tuning fork and giving to the candidate, this is the tuning fork you have to use to check my hearing. So you have to prepare at a reflex level. If you do that how that comes? By only one thing, consistency. Nothing else matters. Consistency, and how disciplined is your schedule, and how you are learning the basics. All those things matters. If you are consistent in your preparation, you will definitely feel confident, and we are here always to help you out whenever you guys need anything. MedExpert team is always open its doors for you. All right, that's the 10 things I wanted to know. So once again, I'll just repeat for people: never ever make any premature attempts. Have a proper time frame. 2, never engage in book mafia. Please don't read unnecessary textbooks, especially this current medical treatment and diagnosis, Harrison's. I don't understand who is circulating these books, because CMDD is mostly, it has guidelines comprised of various things, including US, where UK, they follow nice more than that. All right, then wrong guidance. People just lead like blind leading the blind. People can lead you and put you into a pit. All right, and messy preparation, avoid it. Proper schedule every day, at least consistently allocate some amount of time for your studies, and never overindulge in notes. I told you when to use the notes and when not to use the notes. Lack of revision, very, very, very important. Very, very, very important. Okay, very, very important. Memorizing without knowing the concepts, again, a big no. That is not going to help you anywhere. Like one doctor rightly pointed out, the questions are very ambiguous. By simply memorizing, it won't get you anywhere. and never ignore the past papers. That is very important. And fail whenever you are failing in a question, failing wrong, getting a MCQ wrong, always learn the mistake and correct it immediately before going to the next question, and always know the exam. That is again very important. And one more question: can past test in book form be used or online is perfect? It's up to the way you prepare, doctor, because for me, I prefer books more than online material. But online material has an added advantage. If there is any updation, for example, recent papers or your past papers you want to study, the online is always going to be the best thing. Then, I mean, going ahead and reading from any kind of textbook or anything, because book you never know when they exactly printed. Okay, every day they are also updating. Okay, pastest guy is like that. That guy is a big businessman. Richard, he's a big businessman. All right, so they are updating every time and they are keep on going ahead to the next level. So be ready for that. Always you should be ready for that. So they are more updated. So a book if you're buying is quite okay, but we don't know when they printed the book, what are the amount of questions there in the past test, and after that what updates came. So if you want to be more updated, I would suggest you to stick to the online Q bank. All right, now this is a statistics of MRCP examination last year. Okay, typically in a diet, number of candidates sitting is 1957 Jan 2023. This is from RCP. All right, in 1957, 123 UK based trainees sat for the examination, and 1834 non-UK trainees sat for the examination. The pass equated score is 540. Don't worry about this. First of all, I'm not good in biostats. That is not needed. Okay, this is in general how MRCP started. Okay, this is the pass rate of part 1 in January 2023. As expected, UK centers have higher pass rates. International centers have lower pass rate because UK centers has UK trainees. Same thing happens for PACEs. They get trained in this from the baseline onwards, so they find this MCQs very easy compared to the international candidates. I am in no manner pulling down the international candidates. They are also equally competent. Just in general, they tend to have a higher pass rate than the international candidates. Okay, then there is another statistics, female with male. Surprisingly, last time it was a male candidates outnumber the female candidates. These are some racial stuff which is of no use. Then again, UK trainees and non-UK trainees, in this aspect, non-UK trainees again beaten down the UK trainees. All right, so this is the another statistics. Now comes to the topic wise performance. Who passed in which topic more, which topic people find it easy to go ahead and clear, and which topic people find it tough. People who got into trouble, the topic that pulled people down here are, you can see this graph. All right, you can see this graph here. This clinical pharmacology is a topic that put people into trouble. Dermatology again. Then if you carefully see some of endocrine, geriatric medicine, leave it, there is nothing peculiar about it. Then neurology pulled a lot of people down. Then palliative medicine, obviously. Then if you find psychiatry kind of pulling people down, and then respiratory medicine pulled people down. So there are different topics that can, some people can be absolutely strong in cardiology, they can be weak in neurology. Just get to know where exactly is your weak point is. You have to work on that. This is a typical this is the statistics for part 1 in January 2023. Most candidates, if you see the statistics, they found completely okay with subjects like oncology. Most people cracked it. Gastro, most people cracked it. Then followed by this cardiology, then this hematology, ID, and renal medicine, most people cracked it. And people always found trouble with clinical pharmacology. One more thing I will, yes, medical ophthalmology is also low. Yes, Medical ophthalmology, yes, you're right. Medical ophthalmology also people got into trouble. We are working on it to make things easier for you all. So these are the topics people got into trouble. So these troublesome topics we have to be very aware. Especially, I will tell you one thing: clinical pharmacology. You should be super strong in clinical pharmacology. Our basics lecture covers most of the clinical pharmacology. If you ask me, is that enough? It will be enough for your concepts, but it's not going to stop from there. From there, you have to go back and work out as many MCQs as possible. Almost all the MCQs I would suggest for clinical pharmacology alone. I would strongly suggest you to work out past test, past medicine, and if you get time, please work out one examination MCQs also. When it comes to clinical pharmacology, in MedExpert, we will try to incorporate all the Q banks at the earliest, because we want to cover extensively almost every MCQs possible for clinical pharmacology, because clinical pharmacology and therapeutics is the base and a very important subject. They are asking frequently back to back for MRCP 1 and 2, especially MRCP 1. You should be very, very strong in that clinical pharmacology. Rest of the subjects people find difficult. See, for example, endocrine, dermatology, it's not going to adversely affect. Of course, you have to study, there is no excuse in that. But clinical pharmacology, if you slip down in that, because it carries a maximal amount of question. Clinical pharmacology can come in any form. It can come in dermatology, it can come in cardiology, it can come in neurology. If you are going to slip and fall in that, that will completely bring you down without any question. And a lot of people find neurology difficult. Neurology concepts can be little tricky. Unless you know the concepts and the basics, it can pull you down again. All right. Respiratory medicine, I don't know why last time so much people brought down the respiratory medicine, because questions used to be very straightforward in that. So this is the statistics for 2023. Now 2024, once the diet one comes, we will know which subjects are going to pull down. So you should know which subject you are strong, which subject you are weak. Whenever subject you find it weak, have a mentor, have a senior, and ask them how you can work out on that, so that it will help you. All right. And how many MCQs we should target out of 200? Safer side, don't number. Always target around 140 MCQs. Okay, at least then only you will stand on the borderline. Okay, this is a example of a mark sheet. Okay, candidate's name concealed, and I really thank the candidate for, from the bottom of my heart, for bold enough to show the mark sheet. Okay, this is not to mock anyone, this is for the benefit of other people who are watching and listening to this lecture. Okay, for example, see this candidate. The pass mark is 540. The candidate scored 483. Scored 483. Okay, the candidate is sort of, I think, 57 marks, right? 57 marks short. Okay, so let's see how system wise, specialty wise this went through. Cardiology, the candidate scored 67. It's okay. Clinical pharmacology, 57 is trouble. Clinical sciences, 48, again important subject. Dermatology, she scored 75. That's fine enough. Endocrine, again trouble, 50%. Gastro, okay. Geriatric medicine, it's not going to alter anything much, because the questions are very few. Okay, just leave it. Hematology, good. Infectious disease, 36%, is again going to spell trouble. Medical ophthalmology, 25%. I don't know, a lot of people fumbled in that subject. We will work on that, definitely. Neurology is okay, but 60% is never enough. You should at least score 70 to 80% to be on a safer side. Oncology, palliative medicine, good. Psychiatry, again, candidate spells into trouble. So do in renal medicine, again, trouble. So this is how your marks are calculated. So that is why system wise also you have to simultaneously approach the questions. For example, see this candidate. This candidate had trouble with certain subjects. Those are the weak links for this candidate. So next time when this candidate is going to prepare for the exam, he or she should concentrate on the mark on the paths where I marked as trouble. Clinical pharmacology and therapeutics definitely should concentrate. Endocrine, diabetes, and metabolic medicine definitely should concentrate. Infectious disease definitely. Medical ophthalmology definitely should concentrate. Psychiatry, renal medicine definitely. These are the topics, because many times what happens is we have a thing or a notion like we have a notion like this short subjects, it's not going to help us out much or anything, and they can study at last, or somehow they can mark whatever out of ABCD and clear. No, short subjects can put you into trouble also. This is one example. If she had scored little better in certain things like in medical ophthalmology, in renal medicine and psychiatry, she would have definitely cleared the examination by now. He or she would have definitely cleared. That's spelled trouble. Okay, so whenever you feel certain topics are weak, I'm sorry, sir, I feel certain topics are weak. For those, should I use PJ Kumar or should I use past medicine? I would suggest whichever weak subjects you have, first list of the topics which are going to be asked in the subject. Okay, just to go through this in any simple textbook, that's more than enough. Okay, you go through past medicine notes, whatever it is, but just first list out what are the topics. If it is dermatology, there are list of topics. Beyond that, they never asked anything. You should be strong in the topics. That's all we want you to do. You should be strong in the topics. If it is endocrine, there are certain list of topics are there, which is very important. You have to go through that. It doesn't matter whichever notes or whatever you are going through that. Know the concepts really well. Then followed by that, work out MCQs. Topics I don't, because med expert, if you are enrolling, they have the list of topics covered in all the lectures, because it's not mine alone. Like we are like, many tutors are there, consultants are there, so it's like a mix of all people's hard work and their topic. So if you ask the tutors, they will be definitely helping you out. Okay, definitely helping you out. You ask the moderators, they will help you out what are the topics you should be reading. Just know the topics, that should be more than enough. Then work out the topics. See, this is an example of a mark sheet, how people fumble, what are the issues with the examination. This is a simple example for you. This is a simple example. You can see right in front of you in the screen what went wrong. So know your weak subjects. When in MedExpert, when you start working out the MCQs, you will find which subject you are strong, which subject you are weak. The statistical analysis, like what you see in some past medicine like thing, it is available in the MedExpert. Okay, MedExam expert session. Yeah, you can use it whenever, whichever thing you are feeling difficult, you can feel free to ask the mentor that through the moderators, this topic I feel difficult. They will definitely help you out with the topics and everything. Okay, I think the list of topics has been discussed in some lecture. If not, for the topics list for people who are there, we will definitely keep a separate lecture for that. Okay, all right. And definitely when you see the lecture itself, they'll cover most of the topics, but the MCQs, it is near to impossible to cover all the MCQs. So you have to work out the MCQs. Go to the topics and work out the MCQs. Don't need to just confuse yourself on or read any complex things which is not needed. Okay, this is a sample question paper. You guys have any doubt, you ask me. If no doubts, we will work out some MCQs in our MedExam expert style. Any doubts? Anybody? Please feel free to type in the chat box. I am ready to sit and answer your queries before we are going to work out some MCQs. Any more doubts, or shall we work out? I'll give you 2 more minutes. If anyone has any kind of doubts, please feel free to ask. And people who have failed or fumbled, you are more than welcome to approach our mentors or moderators. They will definitely help you out. You can solve any questions, doctor. First, take one Q bank and finish it, then go to the next. Off the way here and off the way there is not advisable. Otherwise, what we did when we were doing our MRCP 1 and 2 is, we take subject wise. For example, we take cardiology. What we do is, we solve past test, past medicine. And during that time, we had some time in hand, so we also went through one exam. Q bank. So cardiology means we will have one note, we will write down some basic concepts, and then we will solve all the MCQs in all the 3 Q banks. That's it. That subject is over. Next, neurology, all the 3 Q banks. This is my way of approaching things. I don't know, it may be working out for you, but I will still suggest you this. So you will have master over the subjects. How many questions? It depends on how much time you have, doctor. If you have like 4 to 5 hours a day, you can spend. Seriously, you can go for 60 MCQs. You have just 2 to 3 hours at least. Med exam expert, we cover everything. Like, see, if you have 2 to 3 hours, at least minimum 40 questions you target, please. That's what I would suggest. 40 questions at least you should target. Otherwise, that's gonna spell more trouble for you. At least 40 questions you should target. Okay, that's how you have to do. Any more doubts? Shall we work out MCQs? We'll work out MCQs in the way in our 2024 style. We will start. Any doubts? All right. Okay, here we go. The very first question. The recent last year, the questions that has been asked last year. 35-year-old woman presents to general practitioner after developing a rash on leg 1 week after returning from a camping trip. On examination, there is a large erythematous patch on the left lateral thigh, expanding from a red papule at the center. She reports flu-like symptoms and generalized arthralgia. So this is the question. So we need to know what is the diagnosis first. Then we will tell what rash it is. What is the diagnosis? What is the thing we are getting here? A 35-year-old lady is here. And this 35-year-old lady is developing a rash 1 week after returning from a camping trip. On examination, there is an erythematous patch on the left lateral thigh with a red papule. So she's telling she's having a red papule and there is a rash around it. So what is this? The diagnosis is Lyme's disease. Absolutely. So the rash is, what is this rash called? Is it B or C? There is a confusion, right? Because this erythema is attached with so many rash. Erythema is something that is associated or attached with so many types of rash. Okay. The answer is B, erythema migrans. Okay, erythema chronicum migrans. Okay, this can be little bit confusing. Yes, somebody says erythema marginatum here. So first thing we are going to see here is what are the different types of rash associated with erythema. We are not going to in MedExpert work just the MCQs. I don't know how to hide this. This is troubling. Yeah. Not just go away just like that. We will see and learn with actual patient-based learning system. Okay. First thing is erythema migrans, which we saw. This is what you call as a target lesion or a bullseye lesion also you can call. It's like a target, like a bullseye it is. Okay. It has a bullseye appearance. It is seen in Lyme's disease. Again, they may ask Lyme's disease can be due to bite of Ixodes species of ticks. It is due to an organism called Borrelia burgdorferi. How many MCQs are there in a small box? Disease can be asked. The rash can be asked. The tick that caused the Lyme's disease can be asked. The organism can be asked. It's a bullseye lesion. All right. This is erythema migrans. Don't forget. See the lesions once more. Never forget. Next erythema, which confuses people, is erythema gyratum repens. This has been asked in MRCP. This is a paraneoplastic phenomenon, otherwise known as a woody grain appearance with multiple concentric rings. Typically, this is seen in cancer, especially esophageal carcinoma and so many other gastric malignancies. You can find this particular lesion. Okay. Typically, you will find a word in the MRCP examination, woody grain appearance. Okay. Don't forget, once again, I'm telling, woody grain appearance with multiple concentric rings. Okay. Getting it? Woody grain appearance with multiple concentric rings. Right? This is erythema gyratum repens. It's a paraneoplastic phenomenon. First is erythema migrans. I hope none of you will make a mistake in this. Next is erythema gyratum repens. Third erythema, I want all of you to know, is erythema marginatum, because some people answered this as erythema marginatum. What is an erythema marginatum? It's a typical cutaneous manifestation of rheumatic fever. Typical cutaneous manifestation of rheumatic fever. What happens? It's due to infection with group A beta hemolytic streptococci. I hope all of you know two different criterias. Okay, Jones and Duke's criteria. Okay, I'm not going in depth of that. This is an erythema marginatum. It's actually a pinkish lesion that expands centrifugally, especially seen in trunk, axilla, and extremities. It spares the face. This is erythema marginatum. And there is another erythematous lesion that is asked in the MRCP examination is erythema annularis centrifugum. This has been asked. It's an uncommon reaction, but still they asked. Okay, this has a characteristic. One particular thing I want you to remember is there is a central clearing. Central area, there will be some clearing. Always remember, central clearing is the keyword. If they use this keyword and give a lesion, this is erythema annularis centrifugum, means central clearing. Okay, central clearing. For part 2, they will straight away show this picture and ask you what it is. Unless you have seen multiple pictures like this, you will fumble in the examination. All right, treatment is going to be here, vitamin D analog, antibiotics and everything. And there is another thing which you seen in the option here. Erythema toxicum. What is an erythema toxicum? You should know what is an erythema. It's otherwise called erythema toxicum neonatorum. It's a idiopathic skin condition seen in kids. See this erythematous lesion. The characteristic lesion here, they will have eosinophils. They will have eosinophils in the lesion, and also there will be peripheral blood eosinophilia in the patient with erythema toxicum neonatorum. These two things you remember. It just erupts within 24 to 48 hours. Mostly it will go off on its own. And another erythema you should know is erythema multiforme. Here also again you will get a target lesion predominantly in the face and the extremities. High incidence you will find in children and young adults, and most cases of this are due to HSV and mycoplasma. These points you should remember when it comes to erythema multiforme. There are various subtypes. Okay, minor, major, atypical, mucosal. But just to remember one thing, mucosal erythema multiforme is commonly seen in mycoplasma pneumonia. This is one point I want you to remember. And remember the organisms associated with this. Okay, this is the erythema multiforme. What name says? Multiforme means multiple forms. See the lesion here, see the lesion here, see the lesion here, see the lesion here, lesion here, lesion here, lesion here. Various morphology, multiple forms. That's why called erythema multiforme. All right, you guys got it? Then another option that was given, another type of erythema you should know is erythema nodosum. This is nothing other than a panniculitis. Okay, it is a panniculitis. It is seen in leprosy. Okay, see here. See here. This is a panniculitis. Typically, you will see in leprosy. It's a symmetric, tender erythematous nodules in the anterior aspect, especially of the lower extremities. This is erythema nodosum. Erythema nodosum, it can seen in leprosy. We call as erythema nodosum leprosum. Erythema nodosum can occur in multitude of conditions. Multitude of conditions. It's a panniculitis. Always remember. Okay, this is erythema nodosum. Symmetric, tender erythematous nodules, typically in the legs. They will give you in the history. Patient presented with symmetric, tender erythematous nodules, especially in the legs, especially in the lower extremities. You should think in terms of erythema nodosum. Seen in leprosy as erythema nodosum leprosum. It is also seen in various other conditions, including your inflammatory bowel disease. There is another thing which seen in the option which has been asked in the MRCP exam is erythema ab igni. This is a reticulate phenomenon. Typically, the history will be given. Somebody was sitting in front of a fire for quite a long time, and they developed this kind of patterned reticulate pattern rash. Reticulate is a net-like pattern rash. Like I said, caused due to chronic exposure to heat like fire. This is erythema ab igni. I hope all of your concepts are clear about different types of erythema, what it is. Now, none of you should make any kind of mistakes. All right. Now we go to the next question. 61-year-old man who has a cardiac failure is presenting to the emergency department with heart swollen erythematous right grade 2. He is unable to walk because of pain. His medication include ramipril, bisoprolol, furosemide, aspirin, and atorvastatin. All right, he's taking ramipril, he's taking bisoprolol, furosemide, aspirin, and atorvastatin. Hemoglobin, everything is fine. CRP is elevated. White cells are normal. Platelet is okay. Sodium is okay. And serum uric acid is creatinine is slightly elevated to 132. Serum uric acid is 610. So, what is the most appropriate next management step? They're asking the next management step. So, first, what is the diagnosis here? What is the diagnosis here? 61-year-old man with a cardiac failure with a heart swollen erythematous right grade 2. Yes, the diagnosis is gout. No doubt in that. So what you will give him immediately? You're going to give an allopurinol? Definitely not. Why? Allopurinol will cause further increase in the uric acid, and it is going to further precipitate in the gout by mobilizing the uric acid crystals. So you're not going to give benzbromarone, canakinumab. Definitely not. You give colchicine or you give rasburicase. Which is the best option? With this altered creatinine as well, colchicine. Exactly, colchicine is a best option. In clinical pharmacology, they may ask you, colchicine, what is the mechanism of action? It disrupts the microtubule assembly, that you should know. Okay, this is the NICE guidelines, latest one on managing acute flares of the gout. Okay, one second. How to manage the acute flares of the gout. NICE suggests offering a non-steroidal anti-inflammatory drugs and colchicine or a short course of oral corticosteroid for the first line treatment. This is NICE guidelines straight away. We always follow NICE and we always suggest others NICE, and we always incorporate NICE guidelines in all our lecture. And NICE also suggests to add a proton pump inhibitor for people with gout who are taking NSAIDs. Okay, NSAIDs. And consider intra-articular or intramuscular corticosteroid injection if NSAID and colchicine are contraindicated. Always remember, if you find any state where NSAID or colchicine is contraindicated, the next step NICE says is intra-articular or an intramuscular corticosteroid. So the first line NICE says for a gout flare is go ahead and give an NSAID. Colchicine, if not working out, always give an intra-articular or an IM corticosteroid injection. And what NICE says, when there is a proton pump inhibitor, when there is an NSAID is given, always cover a proton pump inhibitor. Cover it up with, okay? And do not offer IL-1 inhibitor to treat gout flares unless NSAID, colchicine, corticosteroids are contraindicated or not tolerated. This you cannot prescribe, a rheumatologist was needed. All right, these are the things about gout in NICE. And some of the things about colchicine adverse effects you should be knowing that can be asked. Most common is diarrhea, nausea, and vomiting. It can cause various other things, elevation of liver enzymes, rashes. It's a rare cause of alopecia as well. Okay, leukopenia, myopathy, elevated CPK, myotonia, oligospermia, oliguria, and renal damage also. Azoospermia, all these things are late adverse effect of long-term use of colchicine. All right, third question. 36-year-old man is referred to the psychiatric clinic concerned that he has trouble expressing his emotions. He says that he always feels cold towards others and finds difficulty to have fun doing things that others would find entertaining. Okay, he has been in the same job for the past 9 years. Most accurate description of this personality. Psychiatry, a lot of people fumbled. I don't know why. It's a very straightforward subject. Now we are seeing a 36-year-old man. He is coming to the clinic. He has trouble expressing his emotions. All right. He feels cold towards others and difficulty having fun doing things that others would find entertaining. What is meant by that? Can anyone tell me the term? You don't enjoy the activity which actually gives pleasure. Typically, some activity that gives pleasure to others, this person is not able to enjoy. What is that called? Anhedonia. Fantastic. Yes. It's called anhedonia. Apathy is another thing. Lack of fun. And it's definitely not a. You know how borderline people look like? They are very aggressive. They won't have any trouble expressing his emotions. Borderline people will go and aggressively express his emotions. If they find somebody is not right, they'll just go blast off. That's what borderline is. Definitely not. Histrionic personality, how they will be. Have you ever noted histrionic? It's all about like they wanted to be the center of attraction for everything. That's what called a histrionic personality. Wherever they go, they want everyone to notice them. They act like that. Paranoid personality, they'll have a fear. They'll have paranoia. It's called paranoid. Paranoia. They'll be afraid to go out, talk, or do anything. It's called paranoia. Then we are left with two things, schizoid and schizotypal personality. Which one of them is the right answer? Which personality find more anhedonic, doesn't want to mix up with other people? Okay, it's between D and E. Good. Now everyone came to a conclusion. It's either D or E. But schizotypal personality, one thing you should all remember is they will have some abnormal or obnoxious or very eccentric behavior. Not this. See, people feeling cold towards others and trouble expressing emotion, you can find in plenty of people. But schizotypal people will do something very, very different that is so atypical of a normal people to do. That's the schizotypal. So this is a schizoid personality disorder. Typically, they will be cold or not interested in others. Usually, they will choose to be alone. Sexual relationship with others are difficult. That's why that's called anhedonia. They will find the relationship going waste. I had a patient like that. That gentleman could not initiate any kind of romance or relationship with his wife. That marriage went in doldrums. Here sexual counselors, everyone tried everything, including some Sennen therapy, this, that, nothing worked out. That went doldrum. Psychiatrist tried his best. Schizoid personality people are like, they are cold. They are not interested in anything. They'll just go to job, they'll come back, they'll sleep. They won't talk to their partner or spouse. They'll be just treating them like another roommate or anything. That's how the schizoid personality goes on. So this is the three things. Schizotypal, like I said, they will have odd ideas. They will also be eccentric. They'll have some unusual experiences. If you go, they'll tell, I found some alien, I found some superpower descending on me, all these things. Whereas schizoid, there will be always social withdrawal will be there. This is the classical thing. There will be withdrawal from social activities, and definitely there will be anhedonia. Paranoid, I don't need to tell. All are like delusional. They'll have some fear and all those things. All right. Then the next question we are going to go and see. 25-year-old woman presents to general practitioner with hematuria, proteinuria in the past 3 months. Her symptoms commenced with frank hematuria for the past frank hematuria 36 hours after an upper respiratory tract infection. BP is 138 by 73, heart rate is 67. She has pitting pedal edema on both ankles. Here, what we find elevated, CRP is elevated, and if you come now, creatinine is elevated. It has urine has blood and protein 2 plus, and renal biopsy shows focal glomerulosclerosis with mesangial hypercellularity. What is the likely diagnosis they are asking? Anti-GBM disease or IgA nephropathy, lupus nephritis, membranous glomerulonephritis, post-streptococcal glomerulonephritis. You should now go ahead and correlate with the timeline. Somebody is having nephritic syndrome, not nephrotic, nephritic picture. There is blood and there is a frank blood post 36 hours after respiratory infection. What is the timeline for post-streptococcal glomerulonephritis? How much time it will take? Will it present, I'm sorry, so acutely in just like what you're seeing in 36 hours, or it will take a long time? Yes, exactly. So the answer is IgA nephropathy. Yes, you are right. IgA nephropathy is the answer. This is a table. I'm not going to explain the full table. This table you can find in Robbins. All right. For all people who are appearing for part 1 and part 2, this table is very, very important. Please read this table. Please go through this table. You should know the light microscopy, fluorescent microscopy, and electron microscopy picture of everything. This table has been given beautifully. PSGN, crescentric, membranous, minimal change disease, MPGN, type 1, IgA nephropathy, what you will find. Perfectly it is given. Okay, perfectly it is given. Please go through this table once. Just once for nephrology. This will yield a lot of marks for you. It's a very, very high yield table. All right, very high yield table. I'm not going to spend and explain everything here, but I suggest all of you go through this table once. Okay, now we go to the next question. Okay, the next question is 26-year-old woman who works at a local floor factory is referred to respiratory clinic for investigation of shortness of breath and wheeze. She feels that the symptoms are worst when she is at work and resolve when she is off work on holiday. Examination in the clinic after period on holiday is unremarkable. There is no wheeze or auscultation of the chest. First, what is the diagnosis? Then you tell me what is the next useful investigation. You're going to take a CT, patch test, radio, allergen, allergo solvent assay test, serial peak flow, or a spirometry. What is the diagnosis here first? Come on, you guys have to answer. What is it? Excellent. This is an occupational asthma. Right. So what you will do for an occupational asthma? Occupational asthma. So you will give them something called as a peak flow diary. Peak flow diary. You can download online in any UK website. It's called a peak flow diary. So they have to keep the diary and they have to use the peak flow meter and they have to note down the PEFR values throughout in the diary. And they have to bring it back to the allergist or an asthma specialist or a pulmonologist. They'll be seeing that and they'll be giving medicine. Based on that, they will be giving the medication. And they will also subject the patient for occupational health checkup and evaluation. So in the future, if they need to change any occupation, that can be recommended as well. That is what happens typically in an UK setting. All right. This is an occupational asthma. All right. Serial peak flow. Now, 20-year-old man is admitted in the surgical ward with small bowel obstruction. He admits to weight loss, night sweats for the past 3 months. So B symptoms are there, right? Laparotomy is performed and biopsy of a suspicious lesion has Burkitt's lymphoma. Which translocation is most likely to be presented in this patient? What is the translocation for Burkitt's lymphoma? 922, 1118, 23, 814, 1418. What is the translocation for Burkitt's lymphoma? Everybody got it? Yes, it's D. 814. This is a table, again a very high yield table. Follicular is 1418. Mantle is 1114. Diffuse large B cell 34. Burkitt's 814. Anaplastic is 25. Maltoma, mucosa associated lymphoid tissue lymphoma, it's 1118. You should know at least for this non-NHL, non-Hodgkin's lymphoma translocations. On a rare occasion, they may ask this. What is the function of the gene involved in follicular lymphoma? It's a suppressor of apoptosis. This tyrosine kinase inhibitor function, tyrosine kinase gene is involved in the anaplastic carcinoma. This has been asked once, long back. This has been asked in MRCP. Okay, this is the next MCQ. Now we go to the next MCQ. Okay, this is little tricky, but you will be getting it. 61-year-old man who has type 2 diabetes and hypertension is brought to the emergency department after collapsing. He has persistent vomiting and is unable to mobilize. he become progressively drowsy over the past hour and become the evidence of nystagmus and a bulbar palsy. He has peripheral vascular disease and has had a previous left femoral end arterectomy. There is global weakness, and magnetic resonance angiogram is suggestive of basilar artery occlusion. Thrombectomy is planned. Which artery should be cannulated? They give a list of options: axillary, brachial, femoral, internal carotid, and subclavian. Don't worry about it. First thing I want all of you to tell, what is the diagnosis here? What is happening to this gentleman? He has all the risk factors. He's a hypertensive, he's a diabetic, he's vomiting, he has nystagmus, he has a bulbar palsy. So this guy is having a posterior circulation stroke. All right, all of you agree with me? This guy is having a posterior circulation stroke. All these things point towards that. Okay, if you listen to our neurology lecture, I have explained in very detail about what is a posterior circulation stroke, how it is different from anterior circulation, what are the symptoms. Everything has been explained to you. This is a posterior circulation stroke. Okay, next. This guy also has a peripheral vascular disease. Okay, peripheral vascular disease, and had a previous left femoral endarterectomy. Now this guy's basilar artery is occluded. So how will you cannulate? How many of you seen thrombectomy? I don't know. Just imagine this patient is right in front of you. Where you will cannulate? Internal carotid. Okay. Anything else? Anything more feasible than playing with these carotids? Any other route? See, you cannot go for any arteries in the lower limb. Okay, because why? He has a peripheral vascular disease. So completely forget all this femoral artery. Done. Leave it. He has a peripheral vascular disease. Subclavian route. How many of you subclavian, where it is subclavian is below the clavicle? Is it a very easy route to go through, or is it little tougher route? Internal carotid. I don't do that here in this gentleman. The easiest and the best way is brachial. Okay, this guy has a posterior circulation stroke, like I said. Okay, the best route for this kind of thing is brachial artery, because it first bypass all the tortuosity of the femoral circulation. Also, through brachial, through vertebral artery, the basilar artery can be easily accessed in this gentleman for thrombectomy. I know definitely MRCP doesn't expect this kind of knowledge from you all, unless you are exposed or you are posted in a neurology unit where there is interventional neurology is happening. Otherwise, it's absolutely going to be tough to know all these facts. But the best route to approach here is a brachial vessel. I confirmed that with one more interventional neurologist when I took this MCQ. Is this the way you guys do? He said yes. That's why I brought this again here. This has been asked very recently. Okay, 74-year-old man now comes with a Lewy body dementia, is brought to the emergency department. I hope all of you know what is a Lewy body dementia. What is a peculiar finding in a patient with Lewy body dementia? Who is going to tell me? He is coming with nausea, vomiting, abdominal distension. His abdomen is firm and moderately distended. Yes, hallucination. Correct. He is suspected to have a small bowel obstruction. So what is the appropriate antiemetic to manage his symptoms? Okay, here is a gentleman with Lewy body dementia. He is coming there. Okay, he is having nausea, vomiting, and he is having abdominal distension. Okay, and you are suspecting a small bowel obstruction. Okay, you are suspecting a small bowel obstruction. So the stomach and the small bowel, you are finding an obstruction. So also the same gentleman is throwing out. So you have to give one medicine. You have to give him one medicine that will stop his vomit. So you have to rationally choose a medication that will bypass the bowel, because there is a small bowel obstruction. If you give drugs like erythromycin, domperidone, metoclopramide, all this will act the bowel and it will try to push the obstruction forward, and it will only worsen his symptoms. Am I right? So you don't give domperidone, you don't give erythromycin, you don't give metoclopramide, because all these drugs acts on a small bowel. So you are left with two options, ondansetron and prochlorperazine. Among this, the best drug here in this gentleman is ondansetron, because it acts straight on the central nervous system and stop the emesis. You're getting in? The best drug is ondansetron. All right, that's the very best drug. And always before giving ondansetron, you have to check the baseline ECG, because it can cause QT prolongation. All right, that's them. Two more questions. 72-year-old woman who has an ischemic heart disease, type 2 diabetes, okay, hypertension, lumbar spine radiculopathy, referred to ambulatory care clinic with pitting edema of both lower limbs. She is otherwise stable and able to manage her own activities of daily living. BP is 145/85. Her heart rate is 65 beats per minute and regular. There are no crackles on auscultation of the chest. There is pitting edema to the mid-shins bilaterally. Simple. What they are asking, which of the following medication is most likely cause of her pitting pedal edema? Which drug here can cause pitting pedal edema? Again, clinical pharmacology. Empagliflozin. Does it cause that or does it helps that? SGLT2 inhibitors, what it does? It actually helps in relieving such thing. Indapamide is kind of a rarest cause. Anything else? Pregabalin, yes, it's one of the rare adverse effect. Not the rarest, but the rare adverse effect. Codeine, definitely it causes. The answer is pregabalin. Typically, we prescribe here as pregabalin M. Pregabalin can cause pitting pedal edema. It binds to alpha to gamma subunit of voltage gated calcium channel. This is an important point you should be knowing for MCQs. Alpha to gamma subunit of voltage gated calcium channel. At least remember voltage gated calcium channel. Yes. So, what are the common adverse effects of pregabalin? Okay, drowsiness, malaise, ulcers in mouth, easy bruising, fluid retention can occur. It can cause weight gain and allergic eruptions. Rare side effects are cholestasis, hepatotoxicity, anorgasmia, dyskinesia, and reversible acute renal graft dysfunction. All these are adverse effects of pregabalin. And this is the list of drugs that drugs causing peripheral edema. These are the drugs that can cause peripheral edema. Which are the drugs? Antidepressants, MAMO inhibitors, antihypertensive medications. Always never forget calcium channel blockers. When I gave MRCP, they asked the same question, but the correct answer was amlodipine. Amlodipine is a calcium channel blocker that causes, and direct vasodilators, hydrolysin, minoxidil diazoxide, beta blockers can cause a lot of drugs. At least remember few drugs out of the list. That's more than enough. The last MCQ, with this we are going to wind up. 25-year-old woman presents to the obstetric clinic for a routine checkup. She's 30 weeks pregnant, okay, and has been feeling tired recently. Levels of which maternal pituitary hormone are recognized to fall in pregnancy? This is a tough one. Unless you are good in physiology and obstetrics, it is gonna spell trouble. Who will answer me? This is the last MCQ. TSH will fall? Or TSH and HCG together will rise the hormone? Will it fall? Which other hormones? Just think. ACTH, no. Because that is one of the reasons for some pigmentary changes in pregnancy. Anything else? Any idea before I show the answer? It's the last MCQ. No, definitely not prolactin. The answer is growth hormone. Okay, the answer is growth hormone. Typically, it rises initially around 15 to 17 weeks. If this is 15 to 17 weeks, the growth hormone levels, this is the growth hormone levels, this is weeks, it rises. Then what happens is, after 15 to 17 week, the placenta is there, right? The placenta will start forming its own hormones. Okay, so this will start giving up placental growth hormone. So this placental growth hormone, everything together will rise to upregulation of IGF-1. This will give a negative feedback loop and the growth hormone will completely fall down. I hope all of you got it. First, growth hormone keeps rising till 15 to 17 week. Okay, then the placenta is there. This placenta will secrete a growth hormone called human placental growth hormone. This growth hormone and this growth hormone, when it goes high, what happens then? It will lead to production of IGF-1, insulin-like growth factor 1, which we use as a screening test for seeing acromegaly. This IGF-1 will give negative feedback loop, and as a result, growth hormone levels will fall. All right, this is how it goes on. It gives a negative feedback and growth hormone levels will fall. So among all the hormones, the hormone that typically falls there to the maximum extent is going to be your growth hormone. I hope all of you got it. Okay, no doubt in that. All right, these are the MCQs we had discussed, and thank you so much for attending this lecture. And if you guys, anybody who failed previously wanted to approach us, please come to MedExpert and talk to us. We are not going to charge anything for talking to us and getting some help. We are ready to help you and guide you, and you are more than welcome to enroll in any of our courses. Our 2024 course is going to start, which we have changed certain previous things, and we are going to do it in a way that will be much beneficial for you all. And please leave your feedback in the groups about how the session went, and so that we will be encouraged to give you more and more free sessions as well along with this. I wish you all the best. Thank you so much. Good night. Bye-bye.